Good afternoon, everyone, and a very warm welcome for joining the webinar organized by HTAS. I am Dr. Pranveer Singh, and I'm a consultant psychiatrist working in a crisis resolution and home treatment team in Essex. I'm also the chair for the HTAS Advisory Group. As you all know, over the last few weeks, it has been an unprecedented situation which has been rapidly evolving, in which we find ourselves now in. I'm streaming live from my office in Essex. We have decided, based on the request from the membership, the home treatment team accreditation membership, to organize this webinar, as these are very challenging times and we don't have any rules as such which are outlined with regards to how our crucial services, including the crisis resolution home treatment teams, should respond and adapt themselves. So main area of discussions for today are going to be examples of responses from the two crisis resolution home treatment teams. These I would be speaking about the ongoing response and adaptations we have been making in Essex. About my team, I would later be joined by Helen Pike, who is a nurse consultant and works in a very different subset of population in Cumbria, Northumberland, Tyne and Weir NHS Foundation Trust. So we will hear two perspectives. My population where I work is mostly moderately to densely populated, and we worked on a traditional crisis resolution home treatment team model. As you all know, that our services are very critical and central to the functioning of the acute mental health care. They provide an alternative to acute admission. They are key services and therefore they need to continue as effective as possible. I would be outlining how we are responding in Essex by keeping forefront in our mind that this pandemic is an unprecedented situation. So the points I would be raising and addressing is, firstly, we must ensure that people continue to have access and treatment from our services. Secondly, we continue to provide the best care possible within the resources we have available. Third principle is we continue to work as a team. Fourthly, we continue to prioritize the care of our patients and make use of local and national guidances, which is very important. Subsequently, we need to be prepared to justify our decisions. So to this end, in our trust, we work in an STP and we have formed a working group of all three crisis and home treatment teams, which consists of consultants, team leads, senior service managers. The population of our crisis teams, the cover we provide to a population of approximately 1.2 million. So we have been doing weekly conferences and based on the discussions on these conferences, we are then making collectively decisions how to respond appropriately. The first important thing, which as you all would be aware, and Royal College of Psychiatrists has also been providing guidance about, is that we are screening all referrals which are coming to our services for potential coronavirus cases by asking the basic questions whether people are being infected or there are any other people in the household, and this is done in line with the local or national advice, and we are following this closely on daily basis. We're also asking people who are being shielded or have underlying health conditions. The college has provided fantastic guidance about managing home visits, and this can be accessed by our website. Recently, we have also noticed that there has been reduction in referrals from the GP surgeries, and it may be due to the fact that most of the GP surgeries are now remotely operating, and we have also noticed that there is some reduction from referrals from other services as well. We are monitoring staffing levels on a daily basis and planning for any unfilled shifts. Handovers are very important, so we so far have been managing handovers with implementation of social distancing measures, but in light of the recent deteriorating situation with increasing risk of CV9 infections to staff, there is now a consideration of conducting the meetings on Microsoft Teams, and this is being set up by our IT department. We have also written to community teams and other stakeholders highlighting the potential pressures on services are likely to build up, particularly with the expectations of reducing mental health beds to approximately 50% as part of the CV19 emergency planning. So we have requested other services to contribute to help us by stepping up the care. All potential home visits are being screened in line with the RC Psych home visits guidance. And if we need to do a home visit, we are identifying by the way of MDT discussions if this is really going to serve a clinical purpose, which we cannot justify by use of video or telephone consultation. And if yes, then we are making use of protective equipment consisting of an apron, gloves and masks, and those protective equipments are again used in line with the recent and up-to-date guidance, which is rapidly evolving. So in summary, I just wanted to say that we must ensure that people continue to have access and treatment from crisis and home treatment services. This is an exceptionally difficult and rapidly evolving situation. Replacement of face-to-face consultations to be considered as much safely as possible, and consultations to be provided by other means, such as by remote consultations using telephone or video softwares. We must consider steps to minimize risk of transmission and ways to protect our own health. I would now pass you to Helen Pike for her perspective and how her services are responding. But I just wanted to say that people can post any questions which we would be looking at, and people would be able to look at the webinar again if they miss the opportunity, as this would be recorded and people can ask for it.
Hi, thank you, Pranveer. I'd just like to start by echoing some of the points that you've outlined and the principles around how our services need to continue to operate in these difficult times, and some of the measures that we've put in place and the guidance that we need to follow, which is changing rapidly. You did touch on your area and the size and population. The information I sent you about the area that I currently work in, which is the southeast part of our trust, which is probably one of the biggest mental health trusts in the country, because we cover across to Cumbria. So our total population is round about 1.6 million. The area I work in is about 450,000. And so my colleagues who are on this webinar work in Newcastle and Gateshead, as well as Northumberland, North Tyneside, and over to Cumbria. So similar to yourselves down in Essex, we've got 4 teams covering quite a large area, which does again vary in the density in terms of population. Some of it's very rural, and in other places it's very densely populated. What we've seen in the last couple of weeks is a reduction in the number of referrals to crisis teams and our liaison colleagues, obviously in response to people, or most people seem to be complying with the guidance to stay at home. But recently, in the past week, we've seen a slight increase in those referrals. And again, just to touch on some of the points that Pranveer made around social distancing and maintaining staff well-being, our managers and leads have been very, very supportive in terms of ensuring that staff well-being is paramount in these changing times. We've just had a telephone discussion this morning in one of our positive practice lessons learned groups, and checking in around staff morale and how staff are day to day is really, really important. So I thought I'd just try and break down some of the things that our managers and leads have put in place to help support staff wellbeing and service delivery, which may be helpful to some teams out there. Our team base in the south is a pretty large open plan office area, so we've had to create lots of opportunities for all staff to practice social distancing. So we've got lots of staff home working. For example, telephone triage, which again, just repeating what you've said, Pranveer, has to be really robust so that we can screen those people who are showing symptoms of COVID-19 and to determine the risks in terms of their mental health. And then when, help us make a decision about who we can see face to face and who we should offer telephone or other types of contact for. So we've got in the team in the south, and I know this is it's done slightly similar in other parts of the trust, just dependent on the team base and where the staff are, but we've got our triage clinicians working from home because we've got mobile kit, laptops, mobile phones, and they can take live calls from our call handlers who are office based in one of our clinical bases, which is no mean feat. I think crisis triages can be a challenging role, and the fact that this has worked since we've put it into practice is all credit to the staff and the support from the clinical leads, really. Also, our home-based treatment staff, they're all working from home. So our daily reviews and MDTs, we have a Skype meeting, so the clinicians Skype in, we'll discuss the cases as we usually do, and then the shift coordinator, who's office-based and supported by clinical leads, will contact those relevant clinicians on shift working from home with their contacts. Some of those might be actual home visits and some face-to-face. Obviously, we're using the personal protective equipment for people who are symptomatic or think they might be. So again, adhering to the guidance, which, as we know, is updating all the time. Our leads and managers, they've all pulled together as well, so they're on a rota, so we've always got some senior presence across the team for operationalising some of these changes, making sure that people are communicated with. It's, sometimes things are changing beginning of the day, the end of the day. So staff are working longer shifts so that they're minimising the amount of time they need to be in a building that's got lots of different people, but also helps with childcare and care of people's families, those kinds of things. So we've got rotas going for that as well, which has been devised and reviewed by the operational managers, and obviously support of our senior directors in our business units. and in order to review the changes, because again, as you said, Pranveer, it is evolving, and we regularly have, for crisis services, a clinical standards group, and we meet once a month to talk about what's new, what's emerging, what we are doing in terms of practice, sharing good practice in our teams. So we're having a weekly teleconference to communicate with each other around how we're managing to adapt to the changes, and then share that back with teams. And a couple of examples this week have been around care plans, around the type of care plan we need if somebody that we're seeing is COVID symptomatic, in addition to the kind of interventions we might be providing for someone's mental health. And in the teams in Sunderland, particularly, we use the 5 Ps formulation. So we've been using that collaboratively, sharing the map with our service users when we're doing home visits. So we're just trying to find and think of ways we can continue to do that if we can't do face-to-face. So we've got, we're just waiting for some feedback from a system that is to set up virtual appointments. Some of our community treatment teams are using that, because that's been working really well. And for since the beginning of February, so the last few months, we've had a very consistent home treatment service, led by our clinical leads, who ensure we've got the same staff working across a 7-day period. Obviously they get the days off, but the same staff who are providing home treatment, which has had a really positive impact on our service users, because we know that that's always been a long-standing bugbear of some of our service users who receive crisis care, seeing lots of different faces because we're a 24-hour service, and we're collecting feedback from service users and carers around this, which obviously we're still trying to execute given these challenging times. And the questionnaire that was developed was co-produced with our service user carer group. We've got an involvement group with volunteers, peers, carers, service users, who we meet with monthly. And that's another challenge for us as well. About we've really got some good groups going with our involvement leads, and it's how we keep those links and communication going, given the fact that we're working within the restrictions. I think that's really covered most of the things that that we've put into place. There might be some of my colleagues who have things that they want to add in. Obviously our medical staff, as well as other professionals, pharmacy, are included in the MDT by actual presence or virtually via Skype, and we'll have a rota base for our medical staff. Some contacts we're doing over the telephone, and some people do still need that face-to-face contact. So these are the things that we're reviewing and monitoring on a day-to-day basis. We've got a core group of admin staff who support us in terms of some of the record keeping and letters, you know, particularly discharge letters to GPs and things. So they've had the same opportunities to practice social distance where we can in the workplace, and rotas for them to work from home also. And I think it's fair to say that it has been very challenging, but it's worked really, really well. But again, I think that's down to people's flexibility and willingness to adapt, and to make sure that we're providing safe services and looking out for each other. Okay.
Thank you, Helen, so much for outlining how the service is responding to the CV-19 crisis. I can see a question being, or a comment rather, being posted, which says we are only seeing those face-to-face where the person cannot access virtual platforms either due to access, ability to engage, or whether the identified risk is of an immediate nature. Yes, I think these are the principles we just touched on, and we just discussed that we should be making more use of, we should consider making use of replacement of face-to-face consultations where possible, but there would be times where we would have to, and we are actually seeing people face-to-face when the identified risk is of an immediate nature. There has been a number of guidances coming out from various organizations, including, I can speak about the guidance from the General Medical Council and also from the medical defense unions, which would actually, in essence, say that yes, it may be justifiable to undertake non-face-to-face assessments. However, considerations, the starting position of a consideration must be that is a face-to-face appointment necessary. If following a video consultation, a face-to-face assessment is required, that possibly should be offered to the patient. So if there are any more questions, if people would like to post any comments or put out any questions, then we can look into those. Helen, do you have anything to add? To the response I just mentioned. Is there anything you would like to add to?
No, not really. Just that I think in general we all agree that where possible we are trying to adhere to the guidance and limit contact. There are some rare occasions where we still do need to provide that, and as long as it's safe to do so.
Yes. I would also like to signpost to some of the helpful resources. And one of the main resources which I've been following is the college website, which keeps updated almost every day, I have to say. And it has very useful resources about management of the staff, the management of the allocated resource and availability of the staff, and how to kind of make decisions around where to deploy the staff. There may be areas where crisis teams, home treatment teams would go under pressure, and it may be then a decision to make at the local level if the staff should be deployed in these areas. Alternatively, there may be situations where where there may be a need to redeploy the staff out of the crisis resolution home treatment teams, particularly to the inpatient wards, which has happened in many places. Just to sum up then, as Helen and I have been speaking about, that in summary, we must ensure that our people that people continue to have access to our teams, and we continue to respond and adapt services appropriately to the level of the severity of this unprecedented crisis which we are all in. It may be that we would reorganize a webinar. We would also have, people would also have the opportunity to post their questions via the HTAS chat through the HTAS team. And we can look into those queries and have a discussion over there, or bring it back to the webinar. I've been just told that there may be some more questions in the Q&A, so I'm going to look into it. Yeah, sorry, I've been now scrolling down. Sorry about that. Yes. So one question is, how are teams managing situations where service users may be entering crisis due to loss of face-to-face contact with their existing support services in a way that helps them maintain a sense of self-efficacy and resilience versus increased dependency on services to contain their distress? I mean, if it is a difficult one, I guess, because it's possibly going to be on case-to-case basis where we will make decisions home to see face-to-face and home not to see face-to-face, because we cannot categorically say that we are unable to provide a face-to-face contact. So if that would be the case, you know, I feel that in such cases we may have to then provide support to such patients. Helen, do chip in if you feel.
Yes, I was just
add on something.
Just making sure haven't muted myself. Yeah, I think that is a real challenge, and we, myself and my other nurse consultant colleagues were talking about this just a couple of weeks ago. We thought for example, that we might see a rise in the amount of 72-hour follow-ups from hospital for people going home, being discharged, because I think we did see more discharges than usual, and I think that might be around a variety of reasons, that people were anxious to get home because of the COVID situation, and whilst community treatment teams are using virtual technology and other things to create appointments, I think there's still that sense of expectation that crisis teams will do what we always do, in a sense that we would be seeing people face to face when others wouldn't. So we've been closely looking at that, and we haven't got any evidence to suggest that because community teams are seeing less face to face that we are seeing more referrals or seeing more people distressed in that sense. They're still maintaining the contact that they previously would have done, and they're still sharing that responsibility around the 72-hour follow-up post-discharge. So that's been really good, certainly in these last couple of weeks, these early stages.
Okay. Thank you, Helen. I've got Bobby from NHS England is here, and he has put a question about the experience of patient feedback and views on using phone and video support. We have been, in our trust, we have been using a video platform known as EQRX, and that's a software which is being used by GPs as well, I understand. And I've been doing some consultations on it. And so far, the feedback we are getting is positive. I think I've also received feedback from my team that some of the patients really like it actually. And we had an elderly patient who really got involved in using that software, and I thought that was therapeutic for him. We had another instance where the patient actually started smiling and laughing because she was finding the use of the video conference quite amusing. So I think it's overall it's quite positive, but I mean, this is just a start, and we have just started using it. On the limitation side, there is a need. I think we need to spend a bit more time than usually we would do on a face-to-face consultation, because you might want to have a feel of, or when you're trying to understand the psychopathology, you may require more time. Capacity-wise, we haven't had any kind of crashes of the software, and so far it has been workable for us. So I think it's a very positive thing that we are able to use it in the current crisis, and I guess it would make us further adapt and develop this kind of technology when the crisis may subside. Alex Thompson, has been one of the consultant psychiatrists is asking or is making a comment that from the acute hospital perspective, what scope is there for getting it right first time and ensuring that the first clinician to see a person can do a full assessment, including gatekeeping to minimize waits for further assessments. Helen, would you like to respond to that? Because I think your teams have a different way of delivering the care. Because I work in a crisis resolution home treatment team, and we actually do not, we do gatekeeping directly, and we do a full assessment, but there are different models in the country, I know, where there are crisis teams which would carry out a separate assessment and then pass it to a home treatment team. There's also a possibility of assessments being done in A&E, and I mean, in my trust, we are actually doing full assessments at the first contact. The last question I have got here is, how have teams been managing to support those with forensic history, those who will determine the home environment is unsafe, as service may have previously been provided in community health base GP surgery? I would think so that this would happen on a case-to-case basis again, depending on the extent of the forensic history. If the team would feel unsafe not to see the person face-to-face in their home, then I would assume that even in normal circumstances, that contact may not be made at patient's home, and alternative provisions would have to be arranged for. Another question is about, has there been concerns from clinicians about attending the emergency department from PLT referrals? I'm not aware what does PLT referrals actually means. Helen knows about it. She would like to come in.
Psychiatric liaison team referrals. So there's been some recent discussions around mental health assessment suites within some of the emergency departments. Again, this is a conversation we've had in the last couple of weeks with our liaison colleagues and as crisis clinicians. I think there's a variety of issues here. Some of it's around people being anxious to go to the ED, or people feeling that that's the right place for them to go, and that there's a general view that we need to be certain that the right people go to ED at the right time to get what they need. And in terms of supporting liaison and how they support the acute trusts that they work into to make sure that people with a mental health need are getting a timely response. So these discussions have recently taken place, which may include a mental health assessment suite within an existing department, so that people can have access to the same levels of support from a medical point of view, from security point of view. Or do we have that away from the acute trust site, or do we have triage from a liaison clinician point of view within an ED department 24/7 to help to make sure that people are reviewed timely and they're seen by the right professionals, whether that's mental health or because it's quite a difficult one, isn't it? Sometimes people don't disclose an overdose, for example, until they're in the process of seeing someone for another medical need, for example. So we just need again to be mindful of how robustly these types of supports within our liaison services in the ED and mental health assessment suites are set up, and having those conversations with our colleagues in liaison and crisis, because we do know that sometimes the service users we see, liaison services see, and we're quite good where we work in a sense. We have good interface meetings with, and some people do feel safe by going to a hospital site. So there's lots of things we need to consider around this. And I just welcome what other sort of views people out there have. We're lucky in our area that we've got 24/7 liaison services in our north, central and south patches. Not so over in Cumbria, but we've got teams that work 24/7 with medical and pharmacy staff within our liaison services.
Thank you, Helen. Just to add on to that, for clinicians who are attending emergency departments, there is also a guidance now issued about what kind of personal protective equipment they should be using. Yeah. And again, it is accessible from the college website, and it's quite helpful and provides an outline of, the protective equipment one should be wearing when attending the emergency department or the liaison teams, which which the emergency department is part of.
Yeah.
One more question here. Have any teams been required to set up a 24/7 crisis helpline? How they have achieved this? We recently, we have been in our trust, we have been implementing the 24/7 crisis response service, and it has started about more than a week ago. We are actually getting calls from people asking for a response, for asking for a help. I think this question possibly is of a bigger nature, and there's a lot of guidance available from NHSE in terms of how the new services are being set up. Obviously, the current crisis does slow it down, but on the other hand, we have also observed that the calls coming through the service are possibly not as many as one would have expected in normal circumstances. Additionally, the staff presence has also been reduced due to number of staff self-isolating themselves or being affected by the CV-19. I don't see any more questions in the conversations box at the moment. Just looking again, just to double check it. I also wanted to mention that it would be useful if members of the HTAS and other teams would like to come forward to discuss in future and to provide an outline of how their services are actually responding. As it's really important that we can learn from each other about the new developing ideas and how we are transforming our services. So I would then really kind of wrap it up now and say that I'd like to just thank Eve and Cassie, who both have worked hard to set this up. Actually, they have been behind the scenes and managing the current session as well. So thank you to them. And I wish that everyone stays healthy and safe, and we continue to provide the best attainable care to our patients. If there are further questions, people could please post through the HTAS web chat and we'll get back to them. And we would organize further sessions. So thank you for joining this afternoon.
Thank you.